All synovial joints are reinforced by ligaments. Now the hip joint has two sets of ligaments. It has intracapsular ligaments, ligaments that are found inside the boundaries of the capsule itself. The first one being this structure here, ligamentum teres. Now it's called ligamentum teres because it's a fairly round structure in cross section, but it's triangular when we actually look at it, so it's cone shaped really. Now ligamentum teres attaches here to the fovea capitis, to the section on the head of the femur that is devoid of hyaline cartilage. It passes over the head of the femur before blending into the transverse acetabular ligament that we mentioned earlier. Here we can see a cross section of the hip joint, so we can see there's the articular surface, that's the articular portion of the acetabulum. Here's the fovea capitis with ligamentum teres attaching into it, passing down between the head of the femur and the non-articular portion of the acetabulum before inserting into the transverse acetabular ligament down here. Ligamentum teres is not a particularly strong ligament and its role is not clear. It's believed to be a protective structure for a nutrient artery that passes into the head of the femur. A large proportion of individuals will have an artery that passes through ligamentum teres before inserting into the head of the femur here and providing the head of the femur with a significant blood supply. Dislocations of the hip invariably lead to damage of either ligamentum teres and or the artery. And in those sorts of situations, individuals that have ruptured this artery, if the artery fails to repair, you can end up seeing avascular necrosis, a death of the head of the femur as a result of loss of blood flow. This usually takes a significant amount of time. So the dislocation of the hip may occur at one stage, and the individual may not complain of symptoms for some years after. The hip joint is further reinforced by 3 extra capsular ligaments. These 3 ligaments are all thickenings in the capsule. They're incredibly strong, very stable, very rarely damaged. The first one is the iliofemoral ligament, and it's this big green structure that we see here. It's a triangular shaped structure that is slightly thinner in the central portion. So consequently, a lot of texts describe this as a Y-shaped ligament. Its proximal attachment is up here at the anterior inferior iliac spine. Fibers then pass to the upper and lower parts of the intertrochanteric line. As I said, the central portion is sometimes devoid centrally, so it gives an appearance of being a Y-shaped structure. The second anterior ligament that we have is this structure here, this orange ligament. This is the pubofemoral ligament, and that arises from the superior pubic ramus and iliopubic eminence, this area of bone around here. It then passes laterally to join with the lower arm of the iliofemoral ligament. The function of both of these ligaments is to limit extension. They will also limit lateral rotation. The lower part of these 2 ligaments, so the pubofemoral ligament and the bottom of the iliofemoral ligament, may also limit abduction, abduction. Posteriorly, we have one ligament, known as the ischiofemoral ligament. This arises from the posterior aspect of the ischium, from the upper part of the body of the ischium. Very strong ligament. The fibers spiral up and over the neck of the femur, blending in with the capsule before inserting into the root of the greater trochanter. Again, the function of this ligament is also to limit extension. So as the femur is drawn backwards, the spiraling of this ligament causes it to tighten up. This time, instead of limiting lateral rotation, the iliofemoral ligament will limit medial rotation. As mentioned earlier, the hip joint is a multi-axial joint. We can produce the movements of flexion and extension, abduction and adduction, and medial and lateral rotation. When assessing a joint movement, we look for not just the range of motion, how many degrees the individual can get, but also the limiting factors. And typically, flexion should be limited by soft tissue apposition. We should see approximately 120 degrees of movement, and the limiting factor being the thigh coming up against the abdomen. Extension, on the other hand, is a far more stable movement. We have about 20 to 25 degrees of extension, and this time the limiting factor is predominantly tension in the extracapsular ligaments and the capsule itself, although tight hip flexors may also be limiting factors here. The movement of abduction involves taking the limb away from the midline of the body, and we have approximately 45 degrees of abduction at the hip, the limiting factor being predominantly tension in the adductor muscles and the lower ligaments, the bottom of the iliofemoral ligament, the inferior capsule, and the pubofemoral ligament. The opposite movement is taking the limb towards the midline, so that's the movement of adduction. Again, there should be anywhere between about 30 and 45 degrees of adduction possible at the hip, and the limiting factor this time being the opposite limb. So soft tissue apposition again. Medial rotation is where the anterior surface of the femur is rotated towards the midline. We have approximately 30 degrees of medial rotation at the hip joint. Main limiting factors this time being the ischiofemoral ligament, the posterior capsule, and the lateral rotator muscles. Lateral rotation, on the other hand, should be significantly more mobile. We have about 60 degrees of external or lateral rotation at the hip. This time, the movement is limited by the iliofemoral and pubofemoral ligaments, the anterior capsule, and the medial rotators. This greater movement of lateral rotation is important for many everyday functions like walking, running, sitting cross-legged, and so on. The surface markings of the hip ligaments can be estimated by identifying the position of certain key bony areas. The anterior inferior iliac spine can be identified by palpating the anterior superior iliac spine, passing 2 centimeters down and 2 centimeters medially. That gives us the proximal attachment of the iliofemoral ligament. The upper arm of the iliofemoral ligament then passes towards the greater trochanter, across to here. The lower arm passes towards the lesser trochanter. The greater trochanter can be palpated, the lesser trochanter has to be estimated. The pubofemoral ligament can then be palpated by, or the proximal attachment of the pubofemoral ligament can be identified by palpating the superior pubic ramus, here, over here, and then passing down to join the lower arm of the iliofemoral ligament. If marked correctly, both ligaments will cross the surface markings of the hip joint anteriorly.